Okay, so welcome back for the middle session for today. We're going to kick off with Innovations in Short Stay Hospitals, a Surgeon's Insight, with Associate Professor Dr Rodda, who's an orthopaedic surgeon from Sunshine Coast Orthopaedic Group. So David is a globally recognised and highly experienced orthopaedic surgeon specialising in hip and knee replacement procedures with an emphasis on minimally invasive technology. He's a pioneer in anterior approach hip replacement and patient-specific robotic kinematically aligned knee replacements. Have I said that right? I hope so. David performs a high volume of these complex surgeries each year. He's not just a skilled surgeon, but also a sought-after mentor in the field of joint replacement surgery. He's the only surgeon on the Sunshine Coast to supervise an international fellowship in anterior hip and knee replacement surgery. The prestigious role involves training orthopaedic surgeons both locally and internationally in advanced techniques for several months under his guidance. So welcome, David. We're very lucky to have you here today.
Thank you. That was a very complimentary introduction, very colourful. Thank you. So the title of my talk is Innovations in Short Stay Hospital, Surgeon's Insight. And I guess my first caveat to this is I really don't like the term short stay. I really prefer to think of a value-based ecosystem of which short stay is just one small part. Short stay really puts the focus on one small aspect of it, and patients don't like hearing short stay. It makes them feel like it's something abnormal, and I think we should normalise this. This should be normal stay hospitals. And I'm seeing things obviously from an arthroplasty perspective, but it should be normal that patients go home day one. That should be absolutely normal. So that's the small caveat I would like to put on this talk. So just a quick introduction. Most of it's already been said. I'm predominantly a joint replacement surgeon. I perform quite a few joint replacements, probably just over 800 by the end of this year. And that gives me a unique, I guess, ability to put systems in my practice that surgeons with smaller volumes can't do. I'm able to invest in that infrastructure, and I'll explain a little bit later why I think that's important. I'd like to share a little bit about my journey through value-based healthcare. But first, let's talk about what's been happening with short stay. So if you look at this graph, back in 2018, the OECD average for joint replacement length of stay was about 8 days, Australia faring slightly better at about 6 days. What we've seen with macroeconomic events, and particularly post-COVID, is that there's been a real push towards short stay. So this graph shows the percentage of short stay performed in the United States. Pre-COVID, only about 25% of patients were performed in a short stay environment. Post-COVID, well over 50%. And these numbers really put Australia to shame in terms of what we're achieving in short stay, or what I like to call normal stay. So from a surgeon's perspective, it's interesting to see how surgeons see all the stakeholders in this game. And obviously the most important stakeholder is the patient. And from the very start of medical training, we're always taught to put the patient first. And I think that most surgeons generally in their practice put patients first. Even commercially minded surgeons, I would like to think that getting good patient outcomes leads to better commercial outcomes for the surgeons, because you get more patients wanting to see you, so it's inherently good for business. The surgeon's perspective of private health insurers. So during my surgical training, I really learned that surgeons have somewhat of a distrust, maybe even a disdain for insurers. And I can't tell you how many times over the years I've heard conversations to the effect of, oh, let's just open X piece of equipment. It doesn't matter, the patient's not paying for it. Or, you know, a cheeky little grin to the orthopaedic rep. Let's just open the ceramic on ceramic bearing surface. You're buying lunch, aren't you? Things like this, these practices on the ward, you know, saying to a patient who's ready for discharge, why not just have a little holiday in rehab? You're not paying for it. And of course, that's not doing any harm to that patient in front of you, but indirectly it's doing harm to every patient out there, both privately and publicly. And it's a bit of an uneven fight for insurers, because surely if a surgeon says they need to open that equipment, surely it's necessary. surely it's done in the patient's best interest. And insurers have really very few mechanisms to help rein that in. Then there's the surgeon's relationship with the hospital. And this can be a positive or negative relationship depending on the situation. On one hand, surgeons are seen as a commodity for hospitals. Sometimes we're viewed as the real customer, not the patient necessarily, but the surgeon is the real customer of the hospital. Sometimes we get looked after really well. Sometimes we get free rooms at the hospital. Sometimes we get all kinds of junkets. And it really depends on the number of hospitals in the area that are vying for your business. It depends on the value of the work that you bring to the hospital. And sometimes the flip side of that is that we have to make compromises. So on a ward round, on a post-arthroplasty ward round, it is very common to be told what day a patient needs to be discharged. Often patients are ready to go home day one, and the charge nurse, not through her fault, but from pressure from above, tells you, oh, this patient needs to go home on Wednesday. You're like, but they're ready to go home today. And like, well, they can't go home. It's crazy. The hospital environment is an interesting one for the surgeon. Then you have the relationship with allied health. You would think that this relationship would have complete alignment. All we want is best outcomes for the patient. But when you dig a little bit deeper, what if the physiotherapists at the hospital is getting pressure to enrol more patients in inpatient rehab, which we know is not necessarily nearly all the time? What if that same physio is getting pressure to enrol more patients in outpatient programs, which in my opinion are arguably worse clinically? Outpatient programs often require a patient to have 4 hours of treatment to qualify for the funding mechanism. So you can imagine a patient who's just had an anterior hip replacement and all they really need to do is go home, watch some TV, get up and take a walk a few times a day and rest, let the swelling go down. And they're doing 4 hours of exercise every day. I'll tell you exactly what happens, and gosh, I'm sure you have this all the time, or maybe not all the time, but I'm sure you see this. That patient comes back at 6 weeks, they've got inflammatory groin pain that is incredibly hard to manage, and they blame you as a surgeon. 4 hours a day. I mean, there's people in Paris, there's athletes in Paris at the moment that don't train for 4 hours a day. It's crazy. So what I learned in my value-based journey is that stakeholder engagement is the most important thing. Keeping the patient at the centre of all decisions and trying to navigate all of these conflicts of interest and all of these various stakeholders and biases. So a few years ago, I had this idea to approach Medibank about a short stay program. So I wanted to understand what the pain points were from the insurer's point of view. Now, this is an old document now. This is called the Surgical Variance Report. It was published in 2017 between Medibank and the College of Surgeons. And basically, it outlined variations in practice. It outlined the pain points for the insurers. So this graph shows the percentage of patients referred to inpatient rehab by certain surgeons. So some surgeons referred 100% of patients to inpatient rehab. Some surgeons referred hardly any patients to inpatient rehab. Now that variation in practice is really a surrogate marker for inefficiency. And they had similar graphs for other outcomes, whether this was prosthesis cost, length of stay, item number utilisation. And basically, we came up with this model. So I approached Medibank, and as a surgeon, I was thinking I was just going to be met with absolute disdain, but I was very pleasantly surprised to see that the guys at Medibank, they just wanted to engage. This was music to their ears, that a surgeon actually wanted to talk to them about how we can do things better. So the nuts and bolts of it was we would use an evidence-based tool to triage who needed inpatient rehab. We'd use evidence-based tools to predict length of stay. We'd use appropriate prostheses according to the Australian Joint Replacement Registry. We would charge the appropriate item number, meaning if you do a basic hip replacement, don't charge for the complex one. Don't charge patients a gap. And Medibank, the guys at Medibank said, that's amazing. We'll pay you more money to do that. And there was really nothing innovative or exciting about this. And I thought, fantastic, surgeons are going to love this. I'll be a hero. And as you probably know, I was a pariah of orthopaedics for doing a deal with the devil. And the College of Anaesthetists didn't think too much of it either. So, but what we've seen, we pushed through some of those initial headwinds, and this program has now treated thousands of people all across Australia, and has been what I would like to think an outrageous success. We did a study on patient acceptability of the model, and patients loved it. We did a study on the safety of the model, and it was very safe and actually compared favourably to, very favourably actually, to traditional models of care. Nothing innovative about it. So we all know the challenges. Everyone in this room knows these challenges. Most of you probably know them better than I do. The private healthcare system is becoming unsustainable. There's a death spiral contributed by ageing population, healthcare inflation, all of these issues. So what do we do about it? And we've seen, I don't know if you guys saw in the AFR yesterday, this was a great article by Michael Smith, and it basically talked about this antagonistic relationship between hospitals and insurers. On one hand, hospital operators are saying that health insurers have got record profits. On the other hand, insurers are saying, well, we're propping up an inefficient system. We're basically paying for these guys to not improve their practices. And probably the truth is somewhere in between. So there is no doubt that hospitals need to fundamentally innovate and adapt. And I think that is the bottom line. There needs to be a whole of system reform. In this article, it talked about profit margins of private hospitals. And you can see that over the last few years, profits have gone down. Some of them are significantly in the red. Talked about private hospital closures. We all know private hospitals are closing. So in this cataclysmic environment for private hospitals, we had a great idea to start hospitals. And so I partnered with Warwick Crosby and Jonathan Edelson to develop a hospital brand where we could really shake the system up. And we aim to be the first hospital group in Australia delivering high-volume, value-based care focused on musculoskeletal care. And our logo is Together We Are Stronger. And it really speaks to the point that we want to collaborate with all stakeholders. If you work in private health insurance, which a lot of you do in the room, you've probably had one of us kicking down your door to have a chat over the last several months. And it's because we want to genuinely collaborate, genuinely understand what the pain points are, and help incorporate that into our systems. So we've got four facilities that we're currently building, with more in the pipeline. And we believe that the innovations, getting back to the topic of my talk, the innovations that are required for short-stay hospitals, or what I would prefer to call value-based hospitals, is smaller centres, highly specialised. Kosh made the point before about nurses that are doing 3 or 4 different specialties, not knowing what to open, and opening all these expensive things totally unnecessarily. You have nurses that do one thing and they do it extremely well. So a specialised workforce. We think smaller hospitals, around 4 theatres, and we think that doing high volume, high efficiency procedures leads to improved experience and improved outcomes. We partner with high quality, high volume surgeons, and we think that will transfer volume from low value environments to a high value environment. And I'm sure there's plenty of stakeholders in this room, very reasonably, that don't like this model, but we feel that it is the way of the future. Integrated care. We believe that the hospital should be involved in this patient's journey, not just while they're in the hospital. They should be involved before that patient comes to the hospital until the end of their patient journey. And we've got models that allow for that. So the requirements of a short stay program, if you like, are very well known. There's nothing innovative about this list of items on the on the screen here. Now, as a high-volume joint replacement surgeon doing 800-odd joint replacements a year, I have the luxury of being able to implement every single one of these things within my own practice. Now, for most surgeons, that's impossible. It's not financially feasible, it's not logistically feasible, but I have the luxury that I can do this because of the volume of my practice. So we believe that these systems and processes that allow high-value care, that allow things like short stay, the intense education that's required preoperatively, the intense follow-up that's required when patients leave the hospital, we believe that that should be provided at a hospital level so that surgeons who do 100 joint replacements can benefit from those same high-value systems. We want to incentivise high-value care, like the Medibank program, like NIB programs, like programs that all the insurers are now talking about to incentivise high-value care. Not all hospitals want to engage with those programs because maybe they don't get paid as much as they used to with old legacy contracts. We accept that we won't get paid as much, and we don't think we should get paid as much because we think we can deliver better care more efficiently. As part of any value-based program, outcome reporting is absolutely critical. Once again, in my private practice, I follow up all patients with PROMs and other outcomes, but I've got a person that's dedicated, that's their whole job, just doing that. Most practices can't do that. And we believe that should be incumbent on the hospital to follow up on those outcomes. And if a hospital is following up on their outcomes and getting better outcomes, well, maybe they should get more funding. Maybe if they're getting better results for your customers, maybe they should get paid more for that. And maybe if there's a hospital that's getting terrible results for your customers, then maybe they should get paid less for that. I don't know, it sounds fair. The difficulty is how you actually collect those outcomes, because a lot of organisations, from hospitals, private health insurers, have tried to crack that nut of getting good data collection, and there are systems out there overseas that are getting very, very good data collection, and we think it's important that hospitals utilise those systems, and that's certainly what we'll be doing. Utilisation of technology to improve member experience. This is something that we use a lot in our practice. Patient engagement apps, these sorts of things. Patient engagement apps are a difficult one. The technology hasn't really been there. I've been heavily involved over several years with patient engagement apps, and they've never quite been useful. I mean, Tony, you'd know from Medacta, like the Medacta Pop app, we tried for years and years and years, and no offence, but it's not that helpful. But there's now technology available that is helpful, and those systems are out there, and hospitals should be using them. Sorry, Tony, I didn't mean to. Sorry, I shouldn't have singled that out. I've seen all the companies' apps, and none of them are really that helpful, in my opinion. So the other thing that needs to change in a value-based ecosystem is the contracting environment. Now, I think everyone in the room agrees with that. It's insane that a patient needs to stay in hospital for 3 days to get the full funding amount, and maybe the full funding amount is too much, but maybe there's a negotiation to be had. Okay, so we need a contracting environment that rewards efficiency and good outcomes. We need to minimise low-value care. Now, this has been a really difficult challenge. How do you stop surgeons from doing unnecessary operations? How do you stop surgeons from doing arthroscopies on every patient over the age of 50 that comes in with a sore knee? Well, what we intend to do, and what we think is a good idea, we think that surgeon autonomy is really important. We don't think we should go down a managed care route. But what about if there were procedures that statistically are low value? Arthroscopies over the age of 50, joint replacements in patients with good Oxford scores. What about if you could collect those procedures that have happened and present them at the audit meeting? So the surgeon stands up at the X-ray meeting and says, on this occasion, I had to do an arthroscopy on a 55-year-old because they had an obstructive meniscal tear and I had to do it. And everyone would say, that's fine, that's absolutely reasonable. But if another surgeon gets up and presents 30 of those same procedures in a month, his colleagues would say that's not reasonable. So we believe the way to minimise low-value care is to just shine a light on those practices and let surgeons, as colleagues, discuss what's appropriate. Keep surgeon autonomy, but try and minimise low-value care. Then there's something that's even harder to measure, I guess, and that's the avoidance of completely unnecessary surgery. So how do you avoid that surgery? What do you do? Well, you have to have non-operative programs. And as a surgeon, I can tell you it is so much easier if that patient that has the 50-year-old patient that comes in, they want that arthroscopy. They come in expecting that arthroscopy. And you can spend 5 minutes consenting them for an arthroscopy, which is not what I do, by the way, or you can spend half an hour telling them why they don't need that arthroscopy and not get paid for it. So there's these perverse incentives to do unnecessary surgery. We need to support surgeons to help them make the right choices. We need to support surgeons with good quality non-operative programs. And I know all the insurers are doing this. Better Knee, Better Me, Healthy Weight for Life. All these sorts of programs are trying to empower surgeons to get patients into these programs. But the uptake, and I may be wrong about this, but the uptake that I see at the coalface is not high. So we need better tools to help surgeons really get patients into these non-operative programs. And we believe that the hospital environment actually has a very, very key role to play in that. So that's my surgeon's perspective. Obviously, I'm wearing a few different hats, but that's my surgeon's perspective on where I think some of the innovations in short-stay hospitals are. Thank you.
Thanks, David. That was very interesting. I've got some questions here, if that's all right,
Sure.
from the
Yeah.
app. They've come through, and there might be any roving in the room. He's going to run around. So an interesting one that's come up before is how do you get the anaesthetist on board with 1, no gap, and 2, no overnight medical cover? Is that easy?
So that's been one of the biggest challenges. When we started this program at a hospital in Melbourne, there was almost a riot amongst the anaesthetists. And we can understand the concerns. They don't want a situation where anaesthetic care is seen as a total commodity that should just be a race to the bottom. But the flip side to that is we don't want anaesthetists doing things that don't enable short stay and are there just to increase coding. And I'm not saying that this is in the majority of cases, but things like using volume expanders just to claim another item number, using an arterial gas, putting in an arterial gas line just to claim another number. We don't want to see that either. We don't want to see morphine-based spinals just to claim another number. So I think there needs to be just an honest discussion with our anaesthetic colleagues who are critical in all of this, and we need to bring them along. In some of these models, I think probably the mistake, actually, if I'm being honest, has been they've incentivised the surgeon more than they've incentivised the anaesthetist. So I think we just need to be a bit more understanding of their pain points. Yep. But I think, yeah, I think that's a big challenge. Yeah.
Thanks, David. A couple more questions coming through, but I don't think that links into what you just alluded to of, is there a reason why perhaps is the Vermont private hospital the one that wasn't perhaps as successful, but it seems easier in Queensland? Is there particular things about the location or particular facilities that have led to more success? Or
I think from a personal perspective, I think my surgical practice was bigger in... So just for people that don't know, I had a surgical practice in Melbourne and then transitioned to Queensland with COVID. So I had a busier practice in Queensland to begin with. So when I started for example, the Medibank no-gap program in Queensland, every patient that came in that was a Medibank patient automatically asked about it, and they were automatically offered the no-gap program. So just by virtue of the practice that I had in Queensland, there's a lot more patients that went through. Yeah.
Is the cohort of patients that are suitable for short-stay surgery growing? Are there any specific constraints restricting them providing this type of care to a wider demographic?
Yeah, no, that's a very good question. So realistically, you just need to use evidence-based tools to predict who's appropriate and who's not. In effect, the overwhelming majority of patients are appropriate for short stay. I would estimate 90 to 95% are appropriate for short stay.
We've got one in the room. Yeah.
Thanks for your talk. Where do you draw the line between the responsibility of the hospital and the responsibility of the doctor?
Yeah.
So, for example, in orthopaedics, we say unnecessary procedures. I mean, or I'll talk about endoscopy, which I know. I don't think it's the hospital's role to tell a patient when they should come back for a colonoscopy, for example. That should be on guidelines, but it should be the doctor's responsibility. It seems that costs and things are going up and compliance in day hospital are going because they're taking responsibility for things that perhaps should be at the doctor level and not the hospital level. Can you comment on that?
Oh, I totally agree. There's certain things that are clinically clearly the doctor's responsibility when a review is necessary, etc. I think more the point I was making was that the hospital should have a responsibility to support that patient through their post-operative period, particularly in a short stay environment, and that includes things like nurse practitioner phone calls, physiotherapy phone calls, make sure that everything's going okay. A lot of the complaints that we get as surgeons are based on, in a short stay environment, if it's not done properly, are those first few days where they don't feel supported. They go home, they've got pain and things that need to be managed. But I think in terms of when is appropriate clinical review, 100% that's the surgeon's responsibility in my opinion. Yeah.
Great. Maybe we'll go. There's lots more questions coming in, and I'm sure maybe if you're around for lunch, people can come and ask you. What about? We'll start with. What do you think? Is a fear of the short stay model for, say, established surgeons or the anaesthetists? Are there people hesitant, or what are they worried about?
I think a common misconception is that short stay models are the harbinger of managed care. I think that's probably the fundamental concern. And that's why I've made the point of talking about what the Medibank model actually is. It's just surgeons doing what is actually evidence-based and clinically appropriate, and in the case of that program, getting paid more to do it. It's just real common sense, and it's not the harbinger of managed care, but I think that just comes with education and it comes with time. So as I said, there's a lot of surgeons against that model when it first came out, and now we're seeing surgeons in some areas falling over themselves to be a part of it. So I think that culture change just takes time.
And relationship building, I think.
Absolutely.
Really being part of that conversation. Well, we might wrap it up there and try and kick back on time, but thank you so much, David, for your time.
Thank you.